Hello, I'm Dr. Matthew Herenstein. I'm an associate professor of medicine at the University of Pittsburgh School of Medicine and a cardiologist. I'm here to present today about coronary artery disease and updates in the field. I have no disclosures related to this presentation. So a brief outline of the presentation. We'll have a case to set the stage. We'll then talk about coronary artery disease risk factors, then medical management of coronary artery disease. Then we'll review some information about acute coronary syndromes and interventional therapy, focusing on ST elevation MI, unstable angina on non-STEMI, and stable ischemic heart disease. So as far as our case, we have a 63-year-old male with a history of coronary artery disease, hypertension, and hyperlipidemia. The patient presented with a complaint of increased dyspnea and occasional left-sided chest discomfort, which radiates to the jaw with walking up a hill or a flight of stairs. The symptoms last about 10 minutes and have been increasing in frequency. His history is such that for his coronary artery disease, he was treated with percutaneous coronary intervention in 2010. His medications include metoprolol tartrate 25 milligrams twice daily, lisinopril 10 milligrams daily, atorvastatin 40 milligrams daily, pantoprazole 40 milligrams daily, and aspirin 81 milligrams daily. His blood pressure is 128/76 and his heart rate is 66 beats per minute. Because of the symptoms, he had an exercise nuclear stress test performed. He exercised for 8 minutes and had similar chest discomfort during the test. His ECG revealed 1 millimeter ST depressions in the inferior leads. To determine risk, we calculate a Duke treadmill score, and that equation comes out to 8 minutes for his exercise time, minus 5 times 1 millimeter for his max ST depression, minus 4 times his angina index score of 1 for a non-limiting angina, which equals -1, which puts him at intermediate risk. He had an LVEF of 66% with normal LV size, and the perfusion scan reveals ischemia in the inferior and inferoseptal walls. With all of this, a cardiac cath was ordered. Here you can see in the before pictures that the patient had disease throughout the right coronary artery, 90% stenosis in the proximal portion, and then in the more distal portion, going into 100% stenosis. You can see that the patient ultimately had 3 stents placed throughout the artery, and he now has a good flow, TIMI3 flow, throughout the vessel. So in terms of risk factors, what are the risk factors you can't control? So certainly increasing age, there's nothing we can do about. Heredity, race, and previous heart attack or stroke. When somebody has these issues, certainly they are at an increased risk and nothing we can change. However, there are a number of risk factors, even more, that we can control, treat, or modify. And those include things like high blood pressure, high blood cholesterol, tobacco use, overweight and obesity, physical inactivity, diabetes, depression, alcohol, and drugs. So in terms of coronary artery disease, it's a reduction of blood flow to the heart muscle due to buildup of plaque in the coronary arteries of the heart. The plaque is the buildup of cholesterol and other substances in artery walls. It can narrow an artery and reduce the flow of blood in arteries that feed the heart. And if a plaque ruptures, it can cause blood clots to form. And if the blood clot blocks an artery that feeds the heart, that's what causes a heart attack. So as you can see in the picture here, in the normal artery, you have a complete 100% opening of the artery with good flow. As you see that plaque build up, the luminal diameter narrows, and you can see that in the cross section in panel B, and such that the blood flow can be compromised to the surrounding tissues. So in terms of our coronary anatomy, we have the right and left system. The left coronary artery, the left main, turns into two major arteries, the one that goes down the front, the left anterior descending, and the lateral artery, or the left circumflex artery. The branches that come off of the left anterior descending are considered to be diagonal branches, and the branches that come off the left circumflex are considered to be obtuse marginal branches. So diagonals are off the LAD, and obtuse marginal branches are off the circumflex. On the right side, we have the right coronary artery, which comes off the right coronary cusp in normal individuals. That continues on, and if the patient is considered to have a right dominant system, that gives off the posterior descending artery branch. If they have a left dominant system, the PDA comes off the circumflex. So when we look at coronary remodeling, this is just a pictorial to show you progression. You have a normal vessel, you have minimal CAD, and then as that luminal diameter narrows due to severe CAD, that's where we can have certainly problems with ischemia. It's important to note, though, that the coronary artery stenosis severity prior to myocardial infarction, particularly in ST elevation MI, what are the stenosis we're looking at? And if you look here, in most cases, the vessel, the type of blockage that causes an ST elevation MI is actually one of the smaller blockages, less than 50%. These are often newer plaques, softer plaques that have more of a propensity to actually rupture. And when they rupture, all the coagulation factors go to that site of rupture and cause thrombus. And when you have 100% blockage, that's when you have a heart attack. Obviously, some of the larger blockages can have that happen as well, but we actually see it's the smaller ones. So why this is important is certainly our more significant blockages, 80, 90, 100% blockages can cause heart attacks, often the non-ST elevation myocardial infarction. And those are more obvious to be seen by stress tests and at later stages. But it's important that even if someone has a 30 or 40% blockage that we often consider to be non-obstructive coronary artery disease, it's very important that we start medical therapy and lifestyle changes right away, because we want to prevent that from, number one, getting larger, and number two, potentially rupturing. The more we can stabilize that plaque, limit its growth, and do the things that we know are good for the heart, the better, to prevent the larger types of heart attacks like the ST elevation MI, and again, progression to a more significant blockage. In terms of medical management of coronary artery disease, there's a classical A, B, C, D, E management. And A is for aspirin and antianginals. B is for beta blocker and blood pressure. C is for cholesterol and cigarettes. D is for diet and diabetes. And E is for education and exercise. And we'll review these. As we think about recommendations, it's important to keep in mind the class of recommendations and level of evidence. This is a more updated scheme. But in terms of recommendations, a class 1 indication is the strongest recommendation we have. It means the benefit far outweighs the risk. Typically a higher level of evidence, more of a consensus in this case, and it is deemed to be useful or beneficial and is a recommendation. Class 2A is the next strongest or a moderate recommendation where benefit still outweighs the risk, just not as much as a class 1, and certainly a very reasonable recommendation to make. A class 2B indication still suggests that benefit is typically greater than the risk, but it's actually greater than or equal to risk, and it's the weakest recommendation that we have. In this case, we consider this may or might be reasonable, may or might be considered, and the usefulness is unknown or unclear. So a class 2B indication is still something that could be helpful, but it's not necessarily something that is must be followed in all instances. Class 3 is broken down in two ways. There's one where benefit equals risk and there's no benefit. So it's not necessarily recommended because there's no increased benefit. And class 3, where there's actual harm, where the risk outweighs the benefit. And certainly this is something we would not recommend to do, or in fact would recommend not to do. In terms of level of evidence, there are different levels here, A through C. A is the highest quality evidence coming from more than one randomized controlled trial. A level B is broken up into randomized or non-randomized. But this is a moderate quality of evidence. And level C is the most limited type of data we have, where we have a level C, which is limited data, or a level C, which is just solely based on expert consensus opinion, not in fact based on any significant large-scale trials or evidence. So let's look at aspirin. It's a class 1 indication, level of evidence A, to start and continue aspirin indefinitely in all patients with coronary disease unless contraindicated. Keeping in mind some of the more recent literature where people are wondering, is aspirin still worthwhile, is in patients for primary prevention and also who meet certain criteria. So if a patient's had coronary artery disease that's significant and a heart attack in the past, they should be on aspirin lifelong. That's not something that's controversial at this point. Next recommendations for patients who are undergoing CABG, aspirin 81 to 325 should be started preoperatively and with 6 hours after surgery to reduce saphenous vein graft closure and adverse cardiac events. And also keeping in mind that those patients have coronary artery disease. And then in the post-PCI stented patients, they should receive 81 to 100 milligrams per day of aspirin indefinitely. So looking at these newer guidelines that have come out from 2021, from ACC, AHA, and SCI for coronary artery revascularization in terms of dual antiplatelet therapy, there are a couple of nuances here. In general, our recommendations are the same, but there's some different things here as we think about what has changed, and that's oftentimes the newer generations of stents. They get better as we go on, and as they get better, there's a less chance of restenosis of the vessel or thrombosis in the early stages. And so the duration of dual antiplatelet therapy continues to fluctuate over time. And certainly as we note that there are problems with bleeding and patients have other complications, we try to be very cognizant of that risk-benefit ratio. And so if you look at the ACS side, it's still the recommendation of at least 12 months of aspirin plus a P2Y12 inhibitor, whether it's clopidogrel, prasugrel, or ticagrelor, and that's for at least 12 months. There is a 2A indication that discontinuation after 1 to 3 months it may be considered, and patients can have monotherapy with the P2Y12. But even then, once the monotherapy is over, then they should go back to an aspirin. For patients who are at a very high risk of bleeding, it may be reasonable to stop a P2Y12 after 6 months, but that's only a 2B indication. So again, that's only may be reasonable. So it's not necessarily something that we recommend in all patients. And the stable ischemic heart disease side, still we want to think about how we continue the antiplatelet therapy. And now it says at least 6 months for aspirin and clopidogrel, but still a greater than 6 months may be reasonable. Again, the same recommendation about if there is a bleeding issue, you might be able to consider monotherapy after 1 to 3 months. In the bare metal side, we know that the recommendation has stayed the same, where you have to have at least 1 month of dual antiplatelet therapy, which is different than the drug-eluting stent, but greater than 1 month may be reasonable. In terms of anti-anginal therapy, it's important to think about all the different tools that we have. There's beta blockers, both types of calcium channel blockers, long-acting nitrates such as isosorbide mononitrate, as well as other anti-anginal drugs like ranolazine. So typically it's important to add beta blockers in these patients. Thinking about the long-acting nitrates as an addition, oftentimes we can even think about adding diltiazem or amlodipine, which may have some anti-anginal effect. And then as a sort of a later stage in patients who still continue to be totally resistant to medical therapy and as well as the interventional therapy, ranolazine or Ranexa may be a reasonable option. So we'll talk about beta blockers and blood pressure next. So in terms of beta blockers, they have multiple effects on the heart that are beneficial for patients with coronary artery disease. They decrease the heart rate, as we know. They decrease afterload, decrease our contractility, can cause less exercise vasoconstriction. The main gist here is that they decrease your oxygen demand. So if someone has blockage or has just had stents put in, you really want to limit the demand as much as possible, and that's what beta blockers can do. They can help to relax or calm down the heart. Recommendations here, you want to start and continue indefinitely in all patients post-MI, ACS, LV dysfunction with or without heart failure symptoms, unless contraindicated. It's a 2A indication to consider chronic therapy for all patients with coronary or other vascular disease or diabetes, unless contraindicated. So certainly if someone's had a heart attack, if someone has heart failure, it's a class 1 indication for a beta blocker. If you just have coronary disease, haven't had a heart attack, it's still recommended. It's not quite as high as the class 1. It's a 2A indication. And there is some literature that maybe we don't need to start it in everybody, but it still remains a 2A indication. In terms of our blood pressure categories, we have a normal, which is less than 120 over less than 80. Elevated blood pressure, as we know, 120 to 129 over less than 80. The current stage 1 hypertension is 130 to 139 systolic over 80 to 89 diastolic. Stage 2 blood pressure, high blood pressure, is 140 or higher systolic over 90 or higher. And our hypertensive crisis is higher than 180 systolic over higher than 120 diastolic. Reducing blood pressure and mortality, so certainly the lower the blood pressure, the better. And as you can see here in these schematics from both systolic and diastolic in the different panels and based on age, you can see that the lower the blood pressures, the lower the mortality. And so certainly important for us to keep the blood pressure as good as possible, and important to impress this upon our patients. We really want to look at the average blood pressure and on a whole try to keep it as low as possible. And I think this is a powerful data point and talking point with our patients. In terms of blood pressure recommendations, for patients who have a normal blood pressure, we still always, of course, want to promote optimal lifestyle habits and reassess on a yearly basis. For those who have the elevated blood pressure category, you want to think more about the non-pharmacologic therapies and reassess in about 3 to 6 months. If you have stage 1 hypertension, you might want to look at the ASCVD risk score, or the patient's 10-year risk. Additionally, if they have evidence of already atherosclerotic cardiovascular disease alone, without having just the risk component. And so if the answer is no, thinking about non-pharmacologic therapies. If the answer is yes, you're still going to think about the non-pharmacologic therapies, but the blood pressure-lowering medications start to enter the equation. And once you get to the stage 2 hypertension, that's when you want to start thinking about adding medications. And certainly if you're resistant or have higher levels of blood pressure, 2 medications off the bat might be the right way to approach it. What are some of the lifestyle modifications you'd want to recommend to your patients? Well, weight reduction. You want to maintain normal body weight, BMI under 25. Doing that to lose weight, about 5 to 20 points of blood pressure reduction with a 10-kilogram weight loss. You could consider recommending a DASH eating plan, which is a diet rich in fruits, vegetables, low-fat dairy, and reduced in fat, maybe 8 to 14 points. You want to restrict sodium intake to less than 2.4 grams per day. Physical activity, you want regular aerobic exercise for at least 30 minutes on most days of the week. And want to keep alcohol consumption to moderate or lower. In terms of considerations for therapies, I think the important point here is that you want to think about what the coexisting conditions that patients have are. So for example, if they have heart failure, those patients are going to need diuretics, beta blockers, ACE inhibitors, ARBs, aldosterone antagonists. So they're going to need to be on all those medications anyway. So you can think about how you can blend that with your heart failure plan, with your hypertension plan. A post-MI patient might not need a diuretic, but as we talked about earlier, still need a beta blocker, might be put on an ACE inhibitor, could be on an aldosterone antagonist. So again, balancing that with your hypertension plan. If you have a high CAD risk, if you have diabetes, certainly you're going to want the patient to be on an ACE inhibitor and ARB, important considerations, chronic kidney disease, and of course, stroke. So it's the main point is just if you're trying to decide, in some cases, you can select basically on your own personal experience. But the main point is to think about coexisting conditions as to how you would make that selection of your first medications. So let's talk about cholesterol and cigarettes. So in terms of cigarette smoking, I don't think this is a surprise to anybody that it's a class 1 indication to recommend to stop smoking. And that also means no exposure to environmental or tobacco smoke. So you want to make sure that the patient is not exposed to their own smoking or to a secondhand smoke in the house, which is important as well. So it's important to ask about tobacco at every visit. You want to advise that the user to quit every time. And I try to recommend it, even if I know patients have not been open to it in the past. I tell them it's my job and I care about them. And I really want to make sure that we're doing the best that we can to advise them of all the things we can do to reduce their cardiovascular risk. You might want to assist in counseling and develop a plan for quitting and arrange follow-up. In terms of cholesterol, there's good and bad cholesterol. The HDL cholesterol is the good kind. The HDL carries excess cholesterol out of our artery walls and back to the liver where it's removed from the body. High HDL lowers your heart disease and stroke risk. LDL cholesterol is the bad kind. LDL is deposited in artery walls. The high LDL raises your heart disease and stroke risk. So what should be who should be on cholesterol medication? And so, we want to go through this and break down and say, how can we make this more simple? So I'll show you the next slide here. And so this is really an algorithm we can think about as to how you decide if someone should be on statin medications, and thinking that there's generally a low threshold to get these people on medication. So if patients have clinical ASCVD or atherosclerotic cardiovascular disease, they should be on a statin. If they're under 75, it should be a high-intensity statin. And if they're a bit older, a moderate-intensity statin. If patients have diabetes mellitus in that 40 to 75 age bracket, and they have a higher ASCVD risk score greater than or equal to 7.5%, it should be a high-intensity statin. If they're less than 7.5%, it should be a moderate-intensity statin. If their LDL is greater than or equal to 190, it should be a high-intensity statin. And if they have just the ASCVD risk score alone of greater than 7.5% for 10-year risk, it should be a moderate to high-intensity statin. So you can see there's multiple ways to get patients on a statin therapy. And here's an example table on the screen here that shows what are some of the different medications and dosages that put you into the low, moderate, or high intensities of statin therapy. And I'm sure you can use this information or very easily search for this. One of the other ways that we can classify patients and see if they would benefit from any additional preventive measures is thinking about calcium score. So you might be familiar with this, a non-contrast CT. A score of 0 is no evidence of plaque. 1 to 10 is minimal. 11 to 100 is mild coronary artery plaque. 101 to 400 is considered moderate. And over 400 is considered to be extensive plaque. And so when you look at this, how can you utilize this as well? Well, and so if someone has an ASCVD risk estimate of less than 5%, really statin isn't recommended and the calcium score isn't going to be helpful in this case. But what about when someone's in a 5 to 7.5%? We already said that, the 7.5 was the marker from before. But, what you're really trying to do is add to that risk profile. So say someone has a lower risk and you say, are you sure there's nothing else to do, or particularly a family history, something else like that? A calcium score can be helpful. And if they have a calcium score that's greater than 0, you would want to consider a statin. So in this case, the test could actually reclassify risk up or down. So that would be beneficial. Certainly, if they have the greater than 7.5%, you're going to want to recommend a statin. If they have the calcium score greater than 0, it certainly more strongly recommends that you should be on it. But once you're in that greater than 20% range, it's really not helpful because your risk is so high already that you should be on a statin. So it's really for that patient who's in that sort of lower risk or upper low risk category where you just want to make sure. And I think the calcium score can reclassify that patient to say, do you have a reason to be on a statin? If you already have a reason to be on a statin, getting a calcium score is not the right test. We'll move on to diet and diabetes. So what are some of the ATP3 dietary recommendations? You want to make sure that you keep saturated fats low. You want to look at the polyunsaturated and monounsaturated fats. Carbohydrates, especially the complex carbohydrates, should only be 50 to 60% of your total calories. And then maintaining fiber, protein, and limiting your cholesterol intake. In terms of weight management recommendations, again, goal BMI should be less than 25. Waist circumference in men should be less than 40 inches. Women less than 35 inches. Class 1 indications to assess BMI or waist circumference on each visit. So this is oftentimes why you check weights in your office. If the waist circumference is high, you want to consider treatment strategies for metabolic syndrome as indicated. And the initial goal of weight loss therapy should be to reduce body weight by approximately 10% from baseline. With success, further weight loss can be attempted if indicated. So main point is you don't want to tell someone that they have to lose 100 pounds off the bat. You really want to make a goal focus of 10% first and then slowly go from there. In terms of diabetes mellitus recommendations, you want to recommend lifestyle and pharmacotherapy to achieve a near normal hemoglobin A1C or less than 7%. You want to recommend, from a class 1 standpoint, vigorous modification of other risk factors such as physical activity, weight management, blood pressure control, and cholesterol management. And also coordinate diabetic care with the patient's primary care physician or endocrinologist. Let's next focus on education and exercise. So the goal that you want to recommend to patients is at least 30 minutes, a minimum of 5 days a week, but ideally 7 days per week. And I think it's important to make a recommendation of how they do it. So certainly it's a class 1 indication to assess risk with physical activity at every visit. You want to encourage the 30 minutes at least of exercise, moderate intensity aerobic exercise. So I think that's the key point, is it should be cardiovascular or aerobic activity, things like brisk walking, on most, preferably all days of the week, supplemented by an increase in daily lifestyle activities. So when patients, tell you that they exercise, it's important to ask what it is, because oftentimes it could just be walking around at work. Well, walking around at work, but stopping as you go from desk to desk doesn't really count as being physically active. You want to make sure it's cardiovascular activity. And oftentimes what I tell patients is, you'll hear from them, they'll say, oh, I can only walk 5 minutes and then I got to stop. Well, what I tell patients, especially those who have time, is if that's the case, walk 5 minutes, then rest 5 minutes, walk 5 minutes, then rest 5 minutes. And if it takes you 60 minutes to do 30 minutes, that's okay. But hopefully over time, if you continue to do that and are committed, you'll find that eventually you can get to that 30-minute mark. So just like weightlifting, you got to do the same with ramping up your conditioning. But if we don't do that, it's going to be very difficult for patients to build back strength and certainly be more physically fit and active. You also want to advise medically supervised programs for high-risk patients as well. Things like cardiac rehab and so forth can be very, very useful tools. So now let's shift our focus to acute coronary symptoms, and we'll talk a little bit more about interventional therapies as well for coronary artery disease. So as we look at coronary flow, we see here that you have a resting flow down at the level of 1 there, and then you have the maximal flow. And as you can see, up through a diameter narrowing of about 60% in general, it stays about the same. As that narrowing, becomes more significant, you reach the 70, 80+% stenosis. Now all of a sudden your coronary flow reserve drops quite significantly. So as you can see, if someone's getting a nuclear perfusion scan and they have a blockage of 50%, their flow is basically preserved. They're not going to necessarily have ischemia, and that test might show non-obstructive coronary artery, might not show any evidence of ischemia, but they could have non-obstructive coronary artery disease. However, as you get to see the luminal diameter narrow quite significantly, now all of a sudden we can start having symptoms and also evidence on our imaging studies. So as we think about the ischemic cascade, you'll have normal function. Those perfusion abnormalities can show up. So even if someone's not having clinical symptoms, because of those changes that I just showed you about coronary flow, we might be able to pick up ischemia on a stress test in advance. In terms of stress echo, we think about the diastolic, but more in particular the systolic dysfunction. And so actually the perfusion scan might pick up things before you even have wall motion abnormalities that appear on a stress echo. So first is normal function, then perfusion abnormalities, then diastolic dysfunction, then regional systolic dysfunction. So actually the stress echo can actually be a later step than the nuclear perfusion scan. Then you might see the ischemic EKG changes, and then, of course, clinical angina. So that's why when you put all of these factors together, like having a stress echo where you have wall motion abnormalities associated with ischemic EKG changes, associated with what we consider to be typical angina, that is very consistent with a concern for obstructive coronary disease. If on the flip side, we see, some wall motion abnormalities, but yet the EKG is perfectly normal, the patient has no symptoms, that would make you wonder, is this a false positive? And so this is how we can put all these things together. In terms of the spectrum of acute coronary syndrome, we see here non-cardiac chest pain is atypical. And as you start to get into the acute coronary syndromes of unstable angina, non-STEMI, and STEMI, you start to see on the EKG the ST wave changes, of course, the ST elevation. Your serum markers as you go from non-STEMI and then, of course, into STEMI become positive. And then important for thinking about risk assessment in those cases and how we treat those particular patients. So certainly with unstable angina, we'll put on all the medications we discussed. You'll start to think about clopidogrel. In patients who now have actually diagnosis of a heart attack in the non-STEMI category, we'll start to thinking about risk and deciding, do they need a 2B3A inhibitor? Is there a heparin drip? Usually would be started if there's a positive troponin. And then, of course, if patient comes into the STEMI, we're thinking about thrombolysis or primary PCI based on the location of where the patient is presenting. So one of the updates in the 2021 guideline for coronary artery revascularization is to really think about a heart team. And a lot of this comes in because we know now that medical therapy is actually quite good. And it's important to think about when do we want to recommend that patient have invasive therapy. As you think about, many years ago, it was thought that everybody should get a stent if they had coronary disease or if they had chest pain. And we know now that stents don't necessarily change outcomes in all instances. So we really want to be thoughtful about the approach that we take and also trying to limit risk, where we're doing the procedure, what kind of procedure we're doing. Should we think about CABG? Is that the right thing to do? Is a multi-vessel PCI the right thing to do? So they introduced the concept of the heart team. which is really based around shared decision making, thinking about risk benefit. If they're going to have some sort of procedure, thinking about the type of procedure they have, what kind of sedation they might have, and then how are we going to manage that patient post procedures, thinking about cardiac rehabilitation, making sure that we really try to focus on getting the patient the best outcome possible, whether it's to perform a procedure or not, and then how we follow that patient up. So let's talk about ST elevation MI. Here's a representative EKG. You can see here the significant ST elevations that we see in multiple leads, most notably the anterolateral leads. So in a patient who comes in with an ST elevation MI, if they're initially seen at a PCI capable hospital, right away as soon as possible, it could be even in the field, we want to activate the cath lab for primary PCI with the goal of being less than 90 minutes of a door to balloon time from the time they enter the door to the time that the angioplasty balloon is inflated, or even in the field. A diagnostic angiogram is performed, and if PCI is possible, patient will have PCI. If it turns out that the patient is not amenable to PCI, could recommend CABG, and certainly as well medical therapy. If the patient is not seen at a PCI capable hospital, but they can get there very quickly, the patient may be flown or transported as quickly as possible to a center for primary PCI, and still try to get in as quickly as possible to relieve that blockage invasively. Otherwise, if the patient cannot get there in a reasonable amount of time, the anticipated arrival time to the device is greater than 120 minutes, you want to perform thrombolysis and administer a fibrinolytic agent. And then afterwards, urgent transfer for PCI for patients with evidence of a failed reperfusion is a 2A indication. Or you want to transfer for angiography and revascularization afterwards if it's part of an invasive strategy. So just thinking about indications for primary PCI, again, in most cases, it's class 1 if you have ischemic symptoms that are under 12 hours. If the ischemic symptoms are less than 12 hours, and contraindications to fibrinolytic therapy irrespective of time, or if the patient is in cardiogenic shock or has acute severe heart failure that's irrespective of time delay from the myocardial infarction onset. In terms of percutaneous coronary intervention, just to review this concept, you see in the balloon angioplasty panel, you have your artery with plaque. The balloon is inserted over top of a catheter. The balloon is placed in the blockage. The balloon is then inflated, and what ends up happening is the plaque does not get pulled out. The plaque actually gets pushed up against the walls, and the artery lumen is open. You now see in panel C that the plaque is sort of pushed up against there, and that's the angioplasty component. But typically, that's not the end of the procedure. That's the first part. Then we do a stent. And so the stent, the balloon is then removed over top of the wire. The stent is then slid back on top of the wire and delivered again into that same location in the plaque. You now have a balloon that is, the stent is over top of a balloon. The balloon is then inflated. The stent is then expanded and opposed to the walls. And now the stent remains in place to keep the vessel open and the plaque pushed up. So the plaque is essentially smushed up against the walls and is still there, and the stent keeps the vessel open. Then what happens is, since the stent is a foreign object, we want to make sure that we continue the dual antiplatelet therapy so that we prevent that stent from having an acute stent thrombosis, as it would be recognized as causing a dissection or causing being a foreign object. And also over time, we hope that with lifestyle changes that we don't get in-stent restenosis, as you still could have that, just like you could have blockage elsewhere. So we've talked about this a couple of times, but recommendations again here for duration of dual antiplatelet therapy in patients with acute coronary syndrome treated with PCI. Important to remember, we still in general for acute coronary syndromes want this to be on for 12 months. There's a couple of outs now if someone has a high risk of bleeding. And certainly in patients treated with DAPT, daily aspirin should be continued forever. And if for some reason patient goes on monotherapy, they should go back on the aspirin afterwards. When we think about treatment algorithm for the timing of elective non-cardiac surgery in patients with coronary stents, this is a question I think that comes up. So, patients just had a stent. When can I send my patient for a surgery? So if the patient was treated with a bare metal stent, then remember, we want at least 1 month of dual platelet therapy. So if it's been at least a month or greater than 30 days, you can proceed with surgery. If it's under 1 month, it's actually considered to be a class 3 or harm indication. So bare metal stents, you want to still wait at least a month before you recommend that they can go ahead and proceed with surgery. If the patient has treated with a drug-eluting stent, if it's been less than 3 months since the drug-eluting stent was implanted, it's considered to be a class 3 indication, so we would not recommend to perform surgery. If it's been 3 to 6 months after implantation, you can consider recommending surgery, but it's a 2B indication. So you remember that is by far the weakest indication where actually risk could even equal the benefit. But typically we want to wait at least 6 months. So 6 months for a drug-eluting stent. It's okay to proceed with surgery. Typically what we recommend is, especially if the patient had acute coronary syndrome, is that the patient would have their surgery if it's really deemed to be necessary, and then go back on to complete their duration of therapy. Now, on the flip side, if this is really an elective surgery, then strongly considering waiting until that 12-month period is quite reasonable. Really depends on risks and benefits also the surgery. Certainly if it's for cancer or something that really can't wait longer, obviously is a little bit different. And of course, if someone ever needs urgent or emergent surgery that's in a life-threatening situation, obviously then the patient needs to go straight to the operating room per the ACC/AHA guidelines, and then we'll have to manage closely their coronary situation as well, and make sure that they don't have any post-procedural outcomes. But of course, we don't want them to die from whatever's going on. So you always have to weigh risks and benefits. So unstable angina and non-STEMI management, we want to think about anti-ischemic therapy with oxygen, bed rest, ECG monitoring, nitroglycerin, beta blockers, and ACE inhibitors. Antithrombotic therapy with antiplatelets and anticoagulants. Important to think about the TIMI risk score. This is one way we can assess patients in terms of their risk for events. And so the factors here are age greater than or equal to 65, greater than or equal to 3 CAD risk factors, a history of CAD, aspirin use in the past 7 days, recent severe angina, less than or equal to 24 hours, increased cardiac biomarkers, and ST deviation greater than or equal to 0.5 millimeters. So this risk score is based on total points of 0 to 7. And you can see there increasing risk of coronary events as you go up to the higher scores. So thinking here, there are 2 different ways to think about your treatment of non-ST elevation MI. You want to think about either ischemia-guided strategy or early invasive strategy. So two different ways you can think about it, and certainly can review this. But it's important that if someone does have a positive troponin, has been diagnosed with a non-ST elevation MI, that you want to initiate dual platelet therapy and anticoagulant therapy. So they should run an aspirin, P2Y12, and then some form of heparin or potentially enoxaparin. If the patient has an early invasive strategy, you might want to consider, you'll certainly consider the same medications, but you might want to then also consider if a 2B3A would also be indicated. And then, of course, deciding how to proceed with catheterization to assess the coronary status. And then from there, deciding, is this a patient who is a candidate for percutaneous intervention with stenting, or does this patient have multivessel disease in which they should go for CABG? And this is really where, as you see in this bottom panel here, where we get to this point with the PCI versus CABG and the late hospital, post-hospital care. In that slide I showed you earlier about some of the newer changes that we've seen in 2021 is that concept of the heart team. And that's really where it comes in. If it's very straightforward, the patient will have the stent placed. But otherwise, that heart team can be very helpful in assessing, is this the right patient who should have a complex PCI? Is this the patient who should have CABG? And then let's make sure we do everything we can to prepare that patient to have the best outcomes with their late hospital and post-hospital care. CURE trial is important to remember as well. This is a trial looking at clopidogrel with a 300 milligram loading dose, followed by 3 to 12 months of maintenance therapy versus placebo in these patients. And what it showed was that clopidogrel loading dose plus long-term therapy reduced the rate of CV death, MI, stroke, and refractory ischemia. And so the main gist is that in patients who have the non-ST elevation MI, even if they're treated medically, continuing them on dual antiplatelet therapy for a year is quite reasonable. This just shows using the TIMI risk score to help predict mortality. And as you can see here, with increasing TIMI risk scores going from 0 to 2 to 4 to 6 and so forth, the mortality at 30 days starts to go up quite dramatically, particularly as we hit that score of 4. You can see from a 2 to a 3, it doubles, and then from 3 to 4. And then as it continues to go up, that number just keeps going up quite significantly. Same thing here. TIMI risk score also predicts 14-day outcomes for non-ST elevation MI and unstable angina. So in terms of just looking at risk, those patients should be really focused on who are the ones who have those higher risk scores as far as how aggressive we want to be with their treatment, both medically and invasively. So looking at our 2021 guideline for coronary artery revascularization or revascularization for patients with stable ischemic heart disease. So these are patients with stable disease again. So if someone comes in and they've got chest pain and they're refractory angina on medical therapy, we talked a little bit about what are some of the medications we can use, but they're still coming in, they're saying, I still have chest pain. So the answer is yes, then you can consider revascularization. Class 1 indication. But let's say they don't have refractory angina on medical therapy. Is there anything else that we need to do in terms of revascularization? Well, if they have left main disease, is it significant left main disease, and is it a high anatomic complexity? So if the answer is yes with left main disease, we want to be more cautious about this, and those patients might be candidates for intervention. And in particular, if it's very clear cut left main disease with CABG, really we don't typically recommend to treat those with stents. We really think about the high-grade left main disease with CABG. But if it's not a suitable candidate for CABG, that's where the heart team can come in and be very helpful and determine what's the best way to proceed. And again, if they don't have significant or complex disease, it can be evaluated separately. If they have multi-vessel PCI with anatomy that's suitable for PCI or CABG, then again, we think about their ejection fractions and factor that in and determine, can we improve their EF? And again, thinking about the heart team approach can be very valuable. If the patient has multi-vessel PCI but is not suitable for PCI or CABG, then again, it would be gold line directed medical therapy. So I think the main gist is really trying to determine if they have continued symptoms despite medications, revascularization. If not, you want to look at their overall picture. How complex is their disease? Do they have 3-vessel disease? Do they have left main disease? If so, determining if there's a particular indication that would push them to CABG or PCI, and if not, that heart team approach can be very valuable. So in summary, risk factor modification is very important. Aspirin and statin therapy should be continued in all patients with coronary artery disease. You want to consider a beta blocker and anti-anginal therapy as indicated. You want to risk stratify to determine treatment strategy in patients with unstable angina and non-STEMI. And patients presenting with ST elevation MI should go straight to the cath lab if available. And lastly, all patients undergoing PCI should be on dual platelet therapy unless also requiring anticoagulation therapy, in which case you can think about what treatment strategy to try to limit bleeding, but also to benefit the patient as best as possible. Thank you very much for your attention.